We have to go back and almost like 40 years regarding the development of ERCP training. ERCP is a technically challenging procedure. It carries high risk, and if it's not done properly, it might create complication and even death of a patient. So that's why it is important for us to provide trainees with the appropriate experience. One of the limiting factors in terms of training is the lack of sufficient number of patients for trainee to practice. So in order to acquire a lot of so-called clinical experience, trainee will have to join special training program. And for example, in the United States, even for a 3-year training program, ERCP is not a regular training activities. Now we are actually moving towards having regular 4th year. That is an additional year of ERCP training and including other advanced endoscopy. In order for the selected trainee to acquire sufficient experience, the reason is that we have to make sure that the trainee know how to perform, know the application and the limitation, but more importantly, learn how to perform a safe procedures, and so that the patient doesn't suffer any complication in addition to the clinical success. Mm-hmm. There are a number of simulation model available over the years, and we can basically divide that into 3 types. The first one the company use would be animal model, and for which the pig stomach model has been used for many, many years and is still being used, except the limitation is that it involves animal tissue, so you cannot apply your clinical equipment in the practice setting, and you have to have special laboratory facilities because you cannot conduct animal practice within the main hospital setting. Also, the anatomy of the pig stomach is quite different to human. So the trainee, when they learn, they may not be able to perform the appropriate procedure. The second type of model would be computer simulators. There have been a couple of computer simulation models available, but what is missing in this, even though they can replicate so-called anatomy using video and simulated motility anatomy, it lacks the tactile sensation of holding the wheel scope and the wheel accessories in performing the procedures. If you use computer probe in terms of performing a procedure, you lack the tactile sensation. The more commonly and perhaps more widely used simulation will be what we call the mechanical simulator. And there are again different types, but the more in quote advanced type is perhaps what we are talking today, the ERCP mechanical simulator, which involve a mechanical model. On top of that, we have incorporated different practice accessories, and more importantly, we have incorporated simulation fluoroscopy so that we can teach trainee the judicious use of radiation in performing the procedure. The model allows the performance from basic dilation to papillotomy to stone extraction, dilation, and stenting of strictures. So pretty much most of the therapeutic procedures that are performed clinically on patients can be reproduced using the EMS model. But more importantly, practice on the simulator allow 2 things, which is very crucial in terms of performing ERCP procedure. Number 1 is the hand-eye coordination. You need to look at the image, you need to reflexively control the scope and the accessories so that you can perform what you plan. The second thing is the tactile sensation, that you actually hold the scope, you have good control of the scope, and you have control over the accessories. The tactile sensation may or may not be able to reproduce easily using even animal models. The more important thing is, in addition to individual learning, the EMS model can provide an opportunity for a teamwork that is between the endoscopists and the assistants, because we all play a different role when perform our procedures. And having a simulator that helps us to focus allow the endoscopists to perform the procedure with the assistant in a coordinated fashion. But the most important thing is the practice on the mechanical simulator does not involve a patient. And you can practice, and you may not, hopefully, create a complication on the patient when you learn your basic skills. I just want to make one emphasis on the practice with the EMS model. That is, I call it the ideal simulation practice, apart from what I already said. I in ideal stand for it improve the basic skill, and D will demonstrate realism. Although people will say, well, there's no motility because it's a mechanical, rigid model, but it does, give us the opportunity to understand the anatomy of the bile duct pancreas, and also in performing the different maneuvers within the system. And E stands for the ease of incorporation into a training program. The simulation or the EMS model is portable. You can actually take it to any endoscopy lab, and because it does not involve any animal tissue, and so there's no limitation. And in fact, you can actually use the clinical equipment. After practice, you can actually reprocess it and put it back into clinical use. So it is a portable system that really can be incorporated with ease into a training program. The A in ideal will stand for applicable in training, because the EMS provide a different practice from simple cannulation to stand placement and other more advanced procedure. It is applicable to both learning, as well as some people can argue you can actually test new idea using the mechanical simulator without having to practice or perform on a patient. The last thing is what I said before is the tactile sensation. You can learn with real scope and real accessories. So you just like driving a car, you're familiar with the operation, and then you can go on to the road. And if you're familiar with the practice on the EMS with the use of scope and accessories, you can actually bring your basic skill to the clinical setting and perform the procedure on the patient with confidence. Coming back to the main reason for using the EMS is to provide more learning and practice opportunity in both allowing success as well as learning to prevent complication on patients. The initial difficulty with the first generation, as I said, if you refer to animal models, you have all the limitation. There have not been a lot of computer simulation development over the years, and the current models available, are still in the, I would call it the rudimentary stage. Other than it can reproduce some anatomy and motility, it lacks the tactile sensation. And over the years, we have seen development that involve improving the model itself, from using rigid tubings and all that to now we're using more flexible material. And the second thing is able to produce some material that conduct electricity, perform cutting. The newer material is moldable, but also allow us to actually perform the cutting using real papillotome and diathermy, pretty much in the same clinical setting. And the newer development is that in the early days, we used an external camera to monitor what's happening inside the bile duct, and people jokingly say, well, you can actually just look at it, it's transparent, we can see. But the most important thing is with the use of a camera that activated to provide an image, it's similar to simulated fluoroscopy. As we know, ERCP involves the use of radiation, and unnecessary exposure to radiation is not considered a benefit for the patient. So we can actually teach the trainee using the simulated fluoroscopy, which is activated with a foot switch, controlling and camera, where we can actually use the camera to project the image while the bile duct and the pancreas is kind of hidden from view. And we have to look at the monitor to appreciate what's going on in the bile duct. ERCP is a three-dimensional procedure. For the endoscopy, we can see a two-dimension. We can see the anatomy and all that. But in order to see what inside the bile duct or the pancreas, we cannot see through the tissue, we have to use fluoroscopy or X-ray to give us a third dimension. That is what's happening inside the bile duct or the pancreas when we perform manipulation. So the development over the years would involve the flexibility of the model, materials similar to or simulating human tissue that allow conductivity and cutting, as well as incorporating the simulated fluoroscopy that help us to monitor the use of radiation in performing these procedures. So these developments are actually moving towards allowing the trainee to practice in a very close to clinical setting without involving a patient. That's a good question. What's happening now is EMS is not a standard or required item in the clinical training. Some programs use it, some programs use different simulator, but the idea of using the EMS model is part of an education program. We still have to teach the trainee the concept, the clinical sense, how to operate and all that, just like any other program without the use of a simulator. The EMS, as I said before, allow the trainee to practice with real scope and accessories in a simulated clinical setting, in addition to learning to use a judicious use of fluoroscopy. What we want to see in terms of the EMS development in training is that hopefully we have a model one day that really can reproduce a lot of the clinical setting or further improvement on the current applicability so that the basic practice does not need to be performed on the patient. Anything that is done unnecessarily on the patient increases risk and potential complication. If we learn the basic using the EMS model and learn all the basic skill, then we can able to apply that. So for example, if you want to learn to hold the scope and manipulate accessory, understand how they perform, you really don't need a patient. You just need to have something that helps you to focus. So practicing on a simulator will allow you to gain a lot of basic experience. So understanding the basics allow you to learn in the clinical setting, the application and the understanding without having to learn how to hold the scope. So you save a lot of clinical cases by not performing the basic technique, where you can actually perform and apply the procedure in a clinical setting. So in a sense that if you have the basic experience, you can cut down on the total number of procedures required to acquire skill at a certain level. Now, the basic transition for a trainee to from a training program is that currently most training programs would have trainee being coached to perform clinical cases by a trainer. And they learn the basic skill, how to hold the scope, how to manipulate accessory, all on the patient. As I said before, if you learn all the basics before you go to a patient, you save some time, you avoid some risk, and you can actually optimize. If you're only given like 50 or 100 cases during your practice, you don't waste the initial 30 cases learning how to hold a scope. You start off from the get-go, learning how to perform the procedure on patient. So you will optimize on the maximum, say, 100 cases, instead of being able to perform only 70 clinical cases while you, in quote, wasted 30 cases learning the basic skill. So the transition is that if we can introduce some form of practice without involving a patient, we can allow the trainee to practice as much as possible, as much as they're willing to spend the time learning the basic skill. But I have to add one thing is that If you allow the trainee to kind of fiddle and fool around with the scope and accessory, they may not learn anything. Practice does not make perfect. Practice only make permanence. If they make the same mistake again, again, and again, they will do the same mistake on the patient. So practice with coaching, that is, it does involve a trainer in the beginning to teach the trainee the basic technique, correct the errors. If there is anything that they're not doing right, to correct them on the spot so that they can develop a good habit. Doing these procedures is just like habit forming and become like a reflex, manipulation, so that if you have enough experience, you will not make the same mistake in a clinical setting. So it does sort of emphasize the role of a teacher when the trainee is learning, just like any other form of training. If the teacher does a good job in teaching, then the trainee will be able to perform. So the transition would be if the teachers or the trainer accept the EMS as a form of alternative to learning basic skill and introduce that to trainees and allow them to practice or encourage them to practice as much as possible. I think the transition to performing clinical procedure will be much smoother, as well as ideally minimizing the number of complications, but increasing the overall clinical success. Well, the important point to point out is that learning ERCP requires the trainee to understand the basics. They have to understand the indication, application, understanding the contraindication, what to do and what not to do. So that is the basics. Then they have to learn how to use the equipment, and that we referred to before, teaching, learning with the scope and accessory, learning the tactile sensation, and then the application in the management of patient. And during this period, it depends on the availability of clinical cases in individual programs. Some programs have more, some programs have less. The American Society for Gastrointestinal Endoscopy, require trainee to at least acquire about 200 ERCP experience, with 75% involved with some form of therapy. But typical example is papillotomy and at least 15 cases of stent placement, so that they understand the basics when they perform. That does not mean that they become fully experienced and qualified, but they have to have some basic experience before they go into so-called solo practice. And the idea of having a minimum requirement is hopefully the doctor will perform a reasonable procedure with good outcome and hopefully no complications. Application of simulation practice, as we said before, hopefully is to increase the basic experience, but the learning and practice on the simulator is not part of a requirement up to now for any training program. Programs that have the option, they will encourage the trainee to practice but many training programs are still relying on allowing the trainee to perform on patient to acquire the experience. To the extent some trainee or fellow graduated, they are still acquiring experience in their clinical practice. But there's no defined number, although there is kind of accepted standard that different society agree to. In Australia, their requirement is more stringent. They require a trainee to perform 200 solo experience. It's different to practice experience before they can be so-called accredited for ERCP practice. So again, different countries may have different standards. Basic requirement hasn't changed over the years. Is to teach a trainee and giving them the knowledge and clinical skills so that they can perform a good procedure. And the idea has not changed over the years, and that basically is the essence of clinical practice, training involved. What has been changed in terms of the teaching program is that Since the introduction of the EMS, we have conducted a number of clinical study, randomized control study. It is one in Taiwan, one in the United States, and also one in Lanzhou, China. That we show that with coached practice, we can teach a trainee with even minimal endoscopy experience to perform cannulation or selective cannulation of the bile duct. And with EMS practice, we increase the success rate when the trainee perform clinical procedures. So there is a difference between practice and clinical practice. For those without the EMS basic practice, their performance is not as good. So it goes to say that we have now 3 control randomized studies that basically show that the EMS can improve basic skill. And the basic skill can be translated into clinical success. Now, obviously, people are asking, if you have other, control study that demonstrate the applicability of, for example, papillotomy, stone extraction, and all that. That's a matter of time if there is a need to perform this type of procedure to confirm success of learning and training in this procedure. But the bottom line is we consider 2 things. Cannulation in ERCP is most difficult. Papillotomy is the most dangerous. If you are successful in cannulating, meaning you can get contrast and a guide wire into the bile duct, you can actually perform a lot of procedures using mechanical exchanges. You can put in a stent, you can put in a drain, you can actually perform a papillotomy if you have a model that conducts electricity. And in learning the papillotomy, we teach the trainee the understanding of the axis orientation and alignment so that we perform a good cut for the bile duct and minimizing the risk of bleeding and perforation, and also allowing success to get into the bile duct, for example, to remove a stone. In another less common situation, we can help putting in a stent. Understanding the basics allow people to perform successfully. We cannot predict too much for the future, but the important thing is that ERCP is a procedure that is going to stay, and we don't see a decrease in the number of patients. The number of trainee or number of doctors wanting to learn ERCP is increasing. So as a result, we have less material for a lot of people, so it dilutes the learning experience. If we can formalize the basic training, I can see that we can continue to offer a larger number of trainees the basic skill learning using or with the help of the simulator. But more importantly, there are other procedures that are being developed in relation to ERCP. You can actually say, well, now I learned ERCP, I can do everything. How is the mechanical simulator going to help me? You say, I have a new technique. In the past, you would say, well, let's try it on a patient and see if it works. It involves 2 things. One is the mechanical manipulation to perform, and also maybe the electrical component to see if we can actually do additional things. The mechanical part is a replication. We can easily reproduce that maneuver on an EMS or mechanical model. So the EMS may provide a testing option or model for trying out new toys, in quote. If you have a new accessories or if you have a new skill, how are we going to help the more senior or the older doctor to learn new skills? Is to allow them an opportunity to practice. But the more senior doctor may not want to say, oh, I'll practice on the patient. That may not be fair, especially, that they are not familiar with the operation. Take, for example, spyglass or the cholecystoscopy. The simulator can actually allow the endoscopist to put the spyglass into the model bioduct and perform the manipulation and get familiar with the equipment before they perform the procedure on the patient. They are familiar with ERCP, they are familiar with all the basic papillotomy and putting material into the bioduct. But for the first time, they put in the new accessories in the bioduct, people may have some reservation. But if they can practice on the simulator, understand all the basics, they probably will feel more confident when they perform this type of newer procedures. And the second thing you can say, well, the application of the simulator may not be just in training. It can be used to compare different accessories. Now, if you have a new stenting system, and you certainly require a large number of patients in order to try out and see if there's a difference. But if you can perform this new stenting method using the simulator, you can actually compare how is it different to the older one, or the more traditional form of stent placement. And it allows people to compare the performance of different accessories, again, without a patient. So it does offer, the opportunity for future research, both in terms of technique, equipment, or material. Well, we have seen a lot of development of the EMS model. Now you can call it the EMS 5.0. There have been a lot of improvement, as I said, from a simple plastic mechanical model to now we have, the flexible tissue. We have tissue that conduct electricity, and we can perform reproducible papillotomy. In addition to that, the ability of the EMS 5.0 is the ability to incorporate removable model of the bioduct or the pancreas that might carry a stone in the bioduct or a stricture in the bioduct, or perhaps, teach people how to perform manipulation in the pancreas. Now, some of these could be challenging. Performing a papillotomy on the pancreatic orifice is not something that many people would do normally, but allowing the technical performance of a cut on the pancreatic sphincter on the simulator will give the trainee at least some experience, or the more experienced endoscopy, some experience in performing. So all of this would help. And as far as the development in China is concerned, we have seen, and actually, put it this way, some 20, 30 years ago, I have used the EMS 1.0 to teach in different hospitals where we conduct hands-on training workshop. Now we can see that because of the increasing number of trainees, we will encourage, or we will hope to see more training center available to provide training. So having a EMS 5.0 that we can reproduce or produce learning opportunity for trainee, but more importantly, with the standardized practice, with a standardized program, we can actually offer a standard way of training. This requires a lot of acceptance by trainers and not just trainees. But if we can formalize the teaching and back up using the mechanical model, we may be able to improve the standard of practice of ERCP in China. Now, what we can do in China, certainly I can see we can reproduce that in other countries internationally. Well, someone who is committed to learning ERCP and all that, obviously, they have a passion. But the most important thing is they have to understand what they're doing. They have to understand what they do to the patient has consequences, not only clinical success, but unfortunately, there are complications. So they have to learn the skill to make sure they can perform successfully and safely. The most important requirement for ERCP learning, as I said before, is hand-eye coordination. You can see, but you need to be able to do something. And the second thing is you have to acquire the technical skill or the tactile sensation that is imparted to you both in holding the scope and holding the accessories to allow you to do a successful procedure. But more importantly, ERCP very often is not considered a solo or one-person procedure. As we sometimes say, it takes two to tango. The endoscopy has to work with the assistant in a coordinated manner, so what we call a team approach, in order to perform a successful procedure smoothly. So it is important for someone who is wanting to learn and willing to learn to acquire the basic knowledge from reading, practice, and all that, but to develop a good team approach, working with assistant to make sure that the procedure can be done. But more importantly, before they do anything to the patient, they have to explain to the patient what they want to do and why they are doing it. So the process of informed consent is very important, not only to the patient, but also to the family. ERCP, as I said earlier on, is a high-risk procedure. It carries complication, and you certainly don't want something bad happen, and then you come back and say, "I'm sorry, I didn't tell you this and all that." Just be upfront and clear to the patient and the family. They are honest and genuine in offering that procedure, helping the patient and the family understand what we are doing, and that would help to ensure success and avoid any unnecessary complaint or complication afterwards. When I was teaching, in Taiwan, explaining to the trainee how to operate on the EMS, and somehow they don't quite understand. As I said, okay, now this is Professor so-and-so, and you're going to perform a procedure. And suddenly they realize that, okay, the EMS is not a toy, it's a patient. And they become very serious. So it is important, but, when exposed to the first time, people would just look, oh, this is just a piece of metal, a piece of plastic. They don't consider that, anything significant. But the most important thing is, can the EMS deliver what we claim? That is, they can practice learning and perform procedure and manipulation and all. If the EMS live up to that expectation, I think the trainee will have some respect on the EMS. And we don't have to just tell them, this is Professor so-and-so when you're performing a procedure. Well, I've told you a couple of small story about the training experience in the past. What I want to see moving into the future is that we can develop a really organized approach to training. EMS is just a tool. The emphasis should not be just working with this model. The emphasis should be, as part of clinical training, teaching the trainee to understand all the understanding material, clinical scenario, all that, helping them understand the basics. The EMS is only part of a device to help them to acquire the technical skill. And then after the technical skill, they have to learn the application of the procedure on the patient and the assessment of outcome. And so the EMS is just part of a learning process, which help people to stay focused. But what I want to see happening would be a program. I've been trying to do this over the last 20, 30 years, working with the Chinese Society of Digestive Endoscopy, helping them to have organized hands-on training workshop. We never quite get there. But on the other hand, there have been increasing interest in getting more learning and training opportunities. So maybe will be a good time that we come out and say, hey, this is a training program where we can detail out all the different practices together with learning material before clinical scenario afterwards, focusing on clinical practice. So, we really want to see an organized program. We have seen the development of the EMS over the last 30 years, from EMS 1.0 to now 5.0. And we hope that we can stay focused and organize a teaching program and realize, the goal of a teacher.